Is it on? Hi. Can you guys hear me okay? Okay. Okay. Well, hello, welcome thank you for coming to our presentation. I'm DeepSight Technology, and this is a company founded in 2019. We are based in Santa Clara, California, and we have offices in St. Louis. We have a disruptive proprietary ultrasound sensor. It has 100 times increase in signal to noise. It's super high bandwidth, wide receiving angle, and the best part is it's an extremely small size sensor. So we can basically put it anywhere. And this is going to revolutionize ultrasound imaging. So we're bringing two things to market, both diagnostic and therapeutic options. So our premium ultrasound system is called Echolux, and it gives everything that a normal ultrasound would and more, and it uses our sensor, so that has that increased signal to noise ratio. But the thing I want to talk to you about today is NeedleVue, and this is what I am most excited to tell you about. So I'm an interventional radiologist. I'm a medical advisor for this company, and I'm also a clinical investigator for DeepSight. But on every day, I'm doing needle procedures. So using CTs, MRIs, and ultrasounds, and I'm putting needles inside of people every day. Some of my procedures are easy, and some of them are very difficult. So I have done my fellowship at Cleveland Clinic in vascular interventional, and so we are doing a large gamut of different kinds of procedures that I have now brought into the rural community where I'm working. And DeepSight is something very exciting that I can't wait to show you guys about. So imagine it's 2 a.m. Someone's in the emergency department, they're bleeding profusely. The reason they're bleeding is because they have portal hypertension. And so I'm involved because I need to do a TIPS procedure. And if you're not familiar, TIPS is when you have to connect the hepatic vein to the portal vein to bypass the blood and decrease the pressure to stop bleeding of varices. So the way we do it is I go through a jugular access, I go down into the hepatic vein, and I skewer into the portal vein, and I put a shunt. In the diagram, it looks pretty easy, but in real life, it's pretty difficult. And this is a real life picture from one of my TIPS. So you can see the portal vein and the hepatic vein. And then after you connect it, there's a shunt that's bypassing the blood, and this will stop your patient from bleeding and save their life. However, when you're in the fluoro room, this is what you see. You can't see the liver, you can't see hepatic vein, portal vein, biliary ducts, arteries. You can't see anything like this under fluoro. So there's a period where you are just puncturing through the liver to try and get into the portal vein. Sometimes you're puncturing and skewering over and over to try and get into that vessel. Very traumatic, very difficult procedure. We have ways of making this a little easier. The old way used to be CO2 portography. I don't know if any of you use that anymore. I don't. Some people have ICE ultrasound, but that requires two operators, someone driving the ICE catheter from the groin and another one doing the puncture. Where I work, I'm a solo IR, so I don't have a partner that could do that for me. And then the way I use is gunsight, where you are using fluoroscopic guidance, getting tangential views. But this is very cumbersome. It takes a lot of radiation and a lot of time to do it this way. So I have not been so happy with these options that are available. And when I'm doing TIPS procedure, you can look at this chart. TIPS procedure is known to be one of the highest fluoro time procedures. And not only is that high amount of radiation to the patient, that's high amount of radiation to me and to my team. So I've always been thinking there must be a better way. And so earlier this year as a SIR, and I was walking by and I saw this booth called DeepSight. And at first I thought, oh, it's just another ultrasound fusion booth. When I looked closer, I could see they were using a transducer, looking at a phantom, looking at tumors. But then I saw this other thing. From the tip of the needle, they were actually seeing ultrasound imaging. And so I went a little closer to look, and this needle has a sensor on it. And when you're using the sensor under ultrasound, you can see whether you're in and out of plane. It tells you in real time, without any magnetic external field, where your needle tip is. And the most amazing part is from the tip of the needle, a 22 gauge needle, you can actually see ultrasound imaging. And so it's not just ultrasound either. All the normal functions of ultrasound, color, elastography, whatever it is normal ultrasounds do, it can do that as well. And so this got my mind racing. I think finally I found the solution to the TIPS problem. Imagine if you had put an internal fiducial in. So you put the sensor on a little 018 wire in the portal vein. Now you put another sensor on the TIPS needle. All you have to do is to touch the two sensors together. It'll localize it for you. And under ultrasound guidance, you can do a one-step TIPS puncture. And then these picture on the side, this is from our laboratory. You can see the picture up there. That's my needle in a explanted cow liver. And you can see the portal vein right there. And that's another degree of safety when you're puncturing in on it, because you could put color flow on that if you want to verify. You would see if there's a hepatic artery nearby so you don't traverse it. So there is very large potential for using this technology in TIPS procedure. But that's just the tip of the iceberg. There are so many different things that we want to investigate. And one of the main things is deep abdominal biopsies. So like if you see this liver here, it's really echogenic. There's a lot of punctate foci. You can easily lose your needle tip in there. But if you just turn on NeedleVue, you can see it'll draw a circle around your needle tip. You'll never have to wonder where your tip is. So here's a case that I had in real life a couple weeks ago. So this is an MRI. You can see there's a gallbladder and there is a gallbladder mass, and it is a mess, and it's invading into the liver parenchyma. So this needs to be biopsied. I go in with ultrasound, and I'm going from my normal view from below the ribs, and I can't see it at all. It's actually pretty high up under the diaphragm. So now I have to go in an intercostal space, which is not my preferred, but it's what I have to do sometime. And if I biopsy it from that side showing, then I'm going to be puncturing through the gallbladder. I could cause a bile leak, so I don't want to do that. But then I try and go from the other way, and there's intercostal ribs in the way. So now I can't go and stay in plane in my viewpoint. I have to go out of plane. And this is a real image from my biopsy. So in that first picture, where do you think my needle tip is? Is it that? That's what I thought it was. But then I later realized it was post-biopsy error when I took the biopsy, and I was in a completely different place than I thought. And this, unfortunately, is a pretty common thing that can happen, where you think you know where your needle tip is, but you don't. And that's a safety issue. And so if I had NeedleVue, I would have seen that first one is I'm completely out of plane, I'm not where I am. And then I would have tracked to find out where my needle tip actually was. So also we could apply this to any kind of microwave, cryo, RF. Our sensor is impervious to temperature, meaning it can be used in the extremes of cryoablation and microwave. And not only can you put it at the tip of the needle, but you could see while putting your cryo probe in, you could see the tumor as you're entering into it from the viewpoint of the needle. Additionally, you can use multiple probes, and they know in relation to each other where they are. And so you would be able to build isotherms and know what your projected isotherm would be for the ablation, which is very handy. Thyroid ablations becoming very popular. I don't know how many of you guys are reading thyroid ultrasounds, but we get quite a lot of things in TIRADs that require biopsy and ablation. And so one thing about thyroid ablation is that you have to be really nervous about the danger space. You do not want to do anything to damage the recurrent laryngeal nerve. And so if we put it on the tip of the needle, you would be able to know where your needle tip was at all times, even with the cloud of ablation that makes your needle tip obscured by normal ultrasound imaging. And so that's my little diagram there with the circle. You would be able to know where your needle tip was at all times and maintain distance from the danger space and the carotid area. So how does it work? Basically, as long as ultrasound can penetrate into an area, our detector will work. It can detect, localize, and display the needle tip, and you can see from the needle tip as well. Unfortunately, I can't tell you exactly how it works, but if anyone is interested, you can come talk to us afterwards. So, nephrostomy, another pretty common procedure. Sometimes it's really easy. You can send your intern, they can do this one, no problem. You could probably poke it blindly and you will get in. But the difficulty comes with these other types. So here is one with mild to moderate hydronephrosis. Kidneys have a lot of different echo textures in them, and so you get a lot of little echo dots all over the place. It can be really easy to lose your needle tip, especially in a large obese person. And so if you have NeedleVue localization, then you can always know where your needle tip is, and you can target directly into that collecting system. So how about this non-dilated kidney? You guys ever put anything in there? It is a very difficult procedure to do. I know that when I do it, it's always a nightmare. I usually start out by giving IV contrast and then get an IV pyelogram, do a puncture on the main pelvis, but that's not where you can enter your tube in. You still need to enter through a calyx. So then you can do a second puncture and hope you can get in, but it's non-dilated, very small system. So then sometimes what I do is I do an air pyelogram, but in this last case that I did that, then the air leaked out and caused a pneumoperitoneum. And so now I can't see by ultrasound anymore, and it's turning into a disaster. And I switched to CT scan. You can see that blue arrow with the tiny little calyx, so difficult to get into, such a troublesome procedure. So I've been thinking about how DeepSight can make this better. Imagine you are putting a sensor on the end of a snare, because this sensor is so small, it can go on anything. And so if you put it on the end of a snare, you could do a rendezvous with your urology colleague. Basically, they could go in from below, put the snare into the collecting system from the ureter, and how that would look to us with a percutaneous ultrasound is that you would see the marker in the kidney. And so you know that's where the collecting system is. That's where I need to puncture into. And you could just touch your needles together, and you're in the collecting system, send a wire through, you have percutaneous access. It can become potentially a very simple procedure. Another type of procedure, which I love to do, is a rendezvous procedure. So sometimes patients have chronic total occlusion of their central veins. And so there's always this gap distance that you have to kind of tunnel through, work through in order to reopen the blood vessel. So here's one of my patients. She was a young lady, 30 years old, chronic lifetime dialysis patient, really bad veins. And you can see she has a really large gap, and it doesn't project well, but there's kissing stents that are occluded. So it's a real nightmare in there. The way that I traditionally do these is you do blunt dissection and try and bridge the gap as much as possible, and then you have to convert to sharp dissection. I do that through a gun sight technique, which requires a lot of tangent view, a lot of fluoro time. And then once you do the sharp recanalization, then you daisy chain into a body floss, and then you can start the procedure. And so you're like 2 hours in, you're already tired, and now you're just getting started. So it's many hours of work to do these recanalization procedures sometimes. And so this is how it looked after the procedure, where I've opened up all of the original vessels and stents. But imagine if we just put our sensor on these, you would be able to do the puncture just like I explained with the other stuff, by making a rendezvous, puncturing with a needle with a sensor into a snare with a sensor, and then threading a wire through. And then you would, all those steps that I mentioned before could be replaced by that simple DeepSight's type of technique. So there's so many applications for this procedure, anything from biopsies to interventional procedures. So our sensor is tiny. It has the potential to go on any catheter, needle, sheath, probe without impacting performance or cost. It's about the size of a thread of hair, very small. It's affordable, it's disposable, it's easy to manufacture, easy to use. There's no external field. So unlike other localization technologies, it doesn't use a GPS field, doesn't put anything into the body, and it's impervious to magnetic fields and temperature, which is great for all of your ablation technologies. It works on any wavelength. So basically any type of ultrasound system, any type of ultrasound probe you have, linear, curved, even ICE, even IVUS, as long as it makes ultrasounds, this technology works with it. And of course, imaging from the tip, that's the NeedleVue, and seeing things from the viewpoint of your needle, something very special that I've not seen anywhere else. So I can think of many solutions, but what can you guys imagine? Basically, this can be applied to any type of interventional procedure you could imagine. And so if you want to come see us, we're at hall booth 6306, which is on the other side. You're more than welcome to see our demo. If you want to put it in your hands and feel it for yourself, come on over. Thank you.